you need to understand physiology. If you can control it, your outcomes will be good. Because even losing 1 liter of blood loss is not going to kill the patient. We can manage it. But 1 liter of blood loss at 33 degrees Celsius of temperature, with the peak of cytokine surge, it becomes a complicated issue. So that's why what is controllable, try to control it. And that is what we do in the perioperative period, and that's why the outcome becomes good. Right, okay. This is what we do for our patients. And the last thing that I will just try to put is the fluid infuser. This is equally important from both the ends. We try to take it. When we say the fluid management usually we divide into periods, right? One is during the cytoreductive surgery. The other fluid management will be during the hypec. Third strategy will be during the reconstruction. If you have done the resection and anastomosis, you want to reconstruct, and post-operative care. Now, when we do the cytoreduction, you remove the organs, try to do something anastomosis sometime at this point or maybe later on. Here, you just have to maintain the fluid. You cannot give a we use the technical term as restricted fluid regimen. And we also try to use certain monitors which are called cardiac output monitors. And we just want to give fluid that is just sufficient to the patient at that point of time. Earlier days, we say if there is 500 ml of blood loss, we have to replace it 3 times the crystalloid. So give 1.5 liter of the fluid. So if there is 1 liter of blood loss, if we give 3 liters of crystalloid, this means this is not restricted fluid regimen. The patient will be definitely so much edematous, even you will not be able to close the abdomen because everything will be swollen up. And if you are not able to close the abdomen, or if you close the abdomen under tension, you understand intraabdominal hypertension and ischemic injury will start happening. So that's why we are cautious in cytoreductive surgeries that those fluid is just sufficient to manage it. And usually we have seen in our experience of last around 12, 13 years that 1.5 to 2 liters is sufficient even for an extensive cytoreduction. Now here comes the role that if we give this restricted fluid regimen, sometimes the blood pressure starts falling. If the blood starts falling, we usually use some amount of vasopressors or inotrophs so that we are able to maintain some pressure so that urine output is okay. And at this stage, we are happy to have a urine output of 0.5 to 1 ml per kg per hour. So if the 50 kg patient, we are okay with 50 ml of urine output at this point of time. Once you start the hypec phase, 60 minutes or 90 minutes. Now, in this situation, we know that the kidney is going to get damaged. It will be inserted. There is no confusion about it. So with this means we have to push the kidney a lot. And herein we give more fluid, right? I was just reserving my fluid from here, which I was supposed to give here. I will give it here now, right? So maybe 4 or 5 hours, I have given around 1.5 liter or 2 liters of fluid. But during this 60 minutes or 90 minutes, I will give another 1 to 1.5 hours of liters of fluid because I want to push the kidney here, right? You are not doing any resection here. Abdomen is closed, is hyperthermia. Some evaporation will also happen. So I'm not much concerned about the overhydration here. But the kidney will be preserved here, and that is what we want at this juncture. Once we give it this, reconstruction is not a big issue. But now since we have followed the regime where we have not overloaded with the fluid, maybe you have a blood loss of around say 1.5 to 2 liters. When you open up the abdomen, it has an ascites. You know ascites is having high protein contents. The proteins are lost. When you do a lot of dissection, more protein oozing happens. Even in your sectioning, you will be taking away more proteins, right? So a lot of protein loss would have happened during the surgical procedure if it is an extensive cytoreduction. Now this needs to be replaced. If you see a post-operative patient in CRS hypec, next 12 hours are actually a turmoil for the anesthesiologist and critical care. So when we do a CRS hypec, Dr. Ray knows that next 12 hours, neither I let them sleep and nor I sleep because we have to manage this patient. Otherwise, in the morning, he will be on 3 inotropes and will be struggling. If you do it nicely in 12 hours, most of the time in the morning, patient is absolutely comfortable to extubate it. What will happen in the post-operative? His lactate levels will go up, kidney function will go down, liver function will start deranging, right? And there will be metabolic disturbance. And majority of time, management is maintaining perfusion and giving good fluids so that all those toxic material will get extracted. So that's why we give a good fluid management in the post-operative period. But remember, you may have done a lot of anastomosis. If you give bolus fluid, I mentioned in the beginning, inflammatory cascade, more leaky capillaries, they will accumulate in more inserted area, and more inserted areas where you have done more resection or anastomosis. If it is accumulates there, your surgical outcome may not be so good. So that's why we give fluids slowly, but on a higher side in the post-operative period for a couple of hours till they settle down. And by experience, we have seen that once you complete HIPEC, next around 6 hours or so, patient will show a deteriorating trend from the metabolic parameters, and then they will start improving. So usually by 10 to 12 hours, they will be on a normal range. So that's why this post-operative care is equally important. Sometimes we do extubate and send to the ward, but be careful that you need to monitor these so that you can help these patients, right? So this is what I have just mentioned, what we do for these patients. So this is nutshell. So here I want urine output of 0.5 ml per kg during the CRS phase. HIPEC phase I want higher, maybe 2 to 3 ml per kg per hour of urine output. Post-HIPEC phase I'm okay with 1 to 2 ml per kg per hour of urine output. So this is how we manage. This is what I just told you. You can just keep in for 30 seconds on the slide. And this is our crux of the fluid management intraoperatively and post-operatively for patients. Right. This I've already covered, so I can skip. Right. Right. So again, coagulation abnormalities I just mentioning about, it can happen because of many things. Fluid shifts, dilutional coagulopathy, ascites, protein loss, all the coagulation parameters have a protein component. If less protein, less coagulation factors, more bleeding. Hyperthermia, chemotherapeutic toxicity, and CF patients are usually hypoalbuminemic patients, proteins are less, nutrition intake is less. So that's why all will cause coagulation abnormalities. Something we can do preoperatively, try to rehabilitate and optimize them, and try to treat it, right? So this is what I can skip those things for you. This I've already discussed for you. I think safety to OT personnel, Dr. Amdi will talk about these personnel because when you do HIPEC procedures, this is absolutely not a safe procedure from the various inhaled, from the tumor tissues as well as the chemotherapeutic agent that he used. So we should be cautious when we are using it. And he has already emphasized in the OT also that we should be careful when we are doing these procedures, right? There's something called IRAS protocol, which we have incorporated into the management of the patients of CRS HIPEC, and you can always manage. And we have published one guidelines from our side, which was published in the Indian Journal of Anesthesia. If you want to learn a little more about the perioperative care, you can go those guidelines, which is published in Indian Journal of Anesthesia, perioperative care for CRS HIPEC. That is what we do. There are many variants, so probably this is the first class, we'll not go into this. There are many variants of HIPEC, PIPEC, NIPEC, APEC, phase, stage. So you can always go through them. We have little differences when we do them. Like for example, PIPEC we have to be little concerned about the gases which are coming from them. When you are doing HIPEC stage procedure, you should understand how to manage so that they come back to the OT for those stage procedures. So these are various variants that we should be looking for, and little modification needs to be done as per the patient requirements. So this is brief for from the anesthesiologist point of view. I know you're all great big surgeons, but your help will help us to remain calm and cool inside the operating room so the patient becomes better. Right, so she's staring at me right on screen. Any questions from this side? I mean, if you want to ask me anything. Right, this is important one. When we say albumin infusion, one, albumin does not have any prophylactic role. So pre-operatively, no need of giving albumin. Somebody asking 3 days of albumin. I said albumin has a short half-life. It's a human product. It causes immunomodulation. It affects the cancer outcome. So we don't give any human products, which is blood or albumin, prophylactic to these patients. If mortality, that's for sure. So we need to rehabilitate them and at least try to bring them 3.5 grams per deciliter of albumin at the time of surgical procedure. With regards to supplementation, preoperatively no role. Intraoperatively, if you see the hemodynamic fluctuations are happening, the pre-op albumin was 3.5. There was source of albumin loss. This means there was a lot of ascites and pooling happening, and patient is hemodynamically unstable. In those situations, Once we have done appropriate fluid resuscitation, then we can add on albumin in each patient. It could be in the form of human products like which 20% albumin comes, or maybe if you have to give appropriate, it also contains the proteins. So you can use them, and then you can continue post-operative for a couple of days. But anything 3.5, then only the indication. If 3.5, then this means there's some other dose, no need to increase beyond 3.5. So that's the rule. And the literature I mentioned, if you ask me around 10 years back, absolutely no albumin intraoperatively. For the last 5 years, there is sufficient evidence that you can use albumin in these patients rather than giving a lot of fluids, crystallized, because that will affect the surgical outcome. It will be good for kidney, but the surgical outcome will be adverse. So in those situations, you can give albumin, but not routine, no prophylaxis.
Sir, if you don't have a facility for a CPET, cardiopulmonary exercise testing, is 6-minute walk test suitable?
Absolutely. So that's how we get markers of doing it. So we say a 6-minute walk test is one of the good screening tool. Only thing is, when we do CPET, it takes up many other components. But if you don't have, I will not say that all patients need it, but then what we do is at least we have some type of stress test. So 6-minute walk test is good. Sometimes when we say the patient has some chemotherapy-induced cardiomyopathies, then we get stress cardiac tests, like stress echo or stress thallium scan for these patients, if they have cardiac morbidity. But otherwise, 6 minutes walk test is good. 2 flights of stairs without stoppage in between, without support, without getting dyspneic is another one. Third is you can always look for the fall in saturation when they go for 2 flights of stairs. Anything more than 4% fall in the saturation is indicated that they do not have reserve. So just now the pulse oximeter are having no small compact one are available. So just measure the pulse oximeter, ask them to go 2 flights of stairs, more than 4% fall. This means results are not good.
So one more question, not related to hyper. If suppose after a major abdominal surgery where we've done multiple dissections and patient post-operatively does have, say borderline BP, fall in BP, how the fluid should be managed in such patients? Should it be supplemented by fluids or inotropes?
Right. So this is important one, sir. Now what we say is, if you see the recent literature specifically for the last 3-4 years, there is something called fluid challenge test. We have to identify this hypotension is because of fluid deficit, or sometimes these patients have something called vasoplasic, sympathoplastic, right? So the vessels will remain dilated and they will not respond. Usually what happens is, if we donate 50 ml of blood, our BP never falls because the patient has its own compensated response. But in these patients, the compensated response is gone away. So we have to identify the cause. Now, how to identify this fluid challenge test? Simple test I will just share with you. You just measure the BP in the supine position, raise the legs for around 60 degrees for around a minute and take the blood pressure again. If the BP improves, because venous return is coming up, so this indicates, this is a rough test, this indicates that patient is fluid deficit. This is one. Second is you can give 200 ml of fluid and see the response, because 200 ml fluid is not going to damage anything to the patient. If the BP improves, the heart rate comes down and the BP starts coming up. The other important aspect is we say pulse pressure. It's just not systolic, diastolic. When the fluid loss happens, the systolic and diastolic blood pressure comes nearing to each other. So that's an indicator of the hypovolemia. If somebody's blood pressure was 110/70, now it comes 110/90, you are okay, that blood pressure is okay. But this reduction of 110/70, 40 to 110/90 of 20 is indicator of early signs of hypovolemia, early indicator. So just give the fluid. Now, if the fluid has been done and the patient is still hypotensive, you can start on inotropes. But usually, we do it intraoperatively. The reason is I don't want to give a lot of bolus of fluids, because bolus of fluids in intraoperative period and just immediate postoperative period is not good for the patient. So I'm giving fluid. So I'll be giving that fluid of 250 ml over half an hour to 60 minutes. But if that half an hour BP is very low, patient will have hypoperfusion injuries. At this moment of time, to buy the time, I will start the inotrope. Fluid will go on. As the fluid replacement is happening, inotrope will come down and I'll stop inotrope. So we have to have a balance of both the aspects, and that will give me both the purpose, good surgical outcome and good perfusion. So I have to balance both the aspects. So this is how we manage the fluid, and this is just yesterday itself, a guideline was released which is related to sepsis. It's a good guideline. The lactate parameters, inotropes, fluids, you can pick up from there. I'll share with Mr. Ray. He can share it with the group, or Dr. Amrita can share it with the group. So that is released just yesterday. It was released as a draft guidelines, and that's one of the best guidelines for us in the sepsis management. So some of the fluid management is very nicely described, and they are very practical this time. Earlier it was more of theoretical and equipment based, but now they are very practical, sir.
So one more question. Sir, just again not related to this, sir, at your institute at AIMS, sir, suppose any major surgery like Oncology, sir, do you have a practice of giving patient vasopressors at the time of anastomosis to maintain a mean pressure say above 75 or 80 or anything?
Vasopressin.
Not vasopressin, any vasopressin, I don't know.
No, principle, see, it's not a prophylactic administration of any vasopressors as such. It depends upon the hemodynamic status. So we don't give it to all patients. It depends that after optimal fluid resuscitation, if the BP is on the lower side, I start the inotropes to buy time. It's not the treatment. It's just to buy time. By the time I understand that why pressures are low, I will give just vasopressors to maintain perfusion. The moment I understand that this is a cardiac event, management is different. This is a hypovolemia, management is different. If you are doing say hepatectomies and all those procedures, I know that you are compressing some maneuver you are doing it, so it will come up moment you relieve it. So I will see that what surgical steps you are. So based on this, I will take a decision. But for that purpose, so the patient does not get hypoperfusion injury, I will start them on inotrope. This is just to buy time. But then we have to treat the underlying etiology why this is happening.
How do you administrate surgery wants hypotension and
So I don't know this is the right platform for that joke or not, but when we have anesthesiologist friends, we usually ask this joke. One of my very good friend is a great friend and a surgeon. When he used to do hepatectomy, he will say, Rakesh, give me a -5 CVP for this patient. I'm doing hepatectomy. I said -5. So he was very happy because I used to give him -5 of CVP. Only thing is I will use just to keep my transistor down and it becomes -5. So just joke apart. So when we say hypovolemia, so hypovolemia is basically that we just discussed with her. So when they are doing hepatectomies or they are working at some procedure, now herein I will not give fluid, sir. Herein I will use the vasopressors and that will maintain the perfusion. Once they are okay, when they have done the dissection, when they have hepatectomy or whatever procedures they have done, they want hypotension, hypovolemia. So one option is I am keeping the fluid lower level, and for maintaining perfusion I am using the drugs which is usually the noradrenaline to maintain the perfusion. This is what, sir. Second is positioning. We usually position the patient if it is allowed, so that the blood is away from the area on which the surgery is being done. So for example, hepatectomies will do just the head up so that it pulls to the lower limb and they are able to manage. Second is positioning. And third is sometimes if some patient is actually hypertensive, then we use drugs like esmolol, or sometimes, not nowadays, but sometimes we use NTG, but usually when they are very high. But majority of time we are happy using esmolol. If patient is preoperatively hypertension and intraoperatively is doing a surge, we use drugs like labetalol. It is a longer acting drug and it keeps the pressure on the lower side. And once the surgery is over, then we are able to reverse it back and bring it back. So this is how we are able to bring the pressures down. But the other aspect is, I know there is something in our chapters, hypotensive anesthesia, which was there 10 years back. But now this concept of hypotensive anesthesia is going away. It is not exactly hypotensive anesthesia because each organ has a different autoregulatory mechanism for its perfusion. So it depends upon what organ you are working. So it will be different for different. So that's why lesser fluid has become now emerged rather than bringing the pressures low. And all those things works well, like hepatectomies or any other surgeries, or sometimes even when you're doing, we see a lot of diffusion, a lot of, you can say like when you see cauterization of various places and you say oozing is happening at different places. So at that time we try to blood pressure low down and so that you can identify, cauterize the things well. But then simultaneously, when you are closing the abdomen, I was saying in the OT also, bring the blood pressure to a little higher normal. right? Bring it to 140, 150, 160 systolic, so that those things which we have stopped by decreasing the blood pressure, post-operative will become normal. And then we don't want the brains to have blood and re-exploration. So during, before the closure happens, we usually try to bring blood pressure to a supranormal level for 5, 10, 15 minutes. Let them see if there is some leftover oozers, small oozers, which if require some treatment is fine. And then we bring them to the normal. So this is how we manage the fluid and pressures. And please excuse me for the joke. It's a trade secret. We don't do it nowadays. But please excuse me for the same.
One important thing is regarding Rakesh. He is the only dedicated. I never seen such a dedicated anesthetist. Because our program is successful. CRS because mostly because of him. He is so dedicated. Even unless patient is extremely, we won't go home like this way. But we don't go. Yesterday we put CRS at 5 o'clock in the evening. In the government setup, anybody I think in this world can't do this. So he can do. He is an exceptional person. He is an academician. So really, we are very much grateful and thankful to Dr. Rakesh.
Thank you so much.
Thank you.
मेजर साहब इतने दिल के क्लोज है तो उनको मना करना थोड़ा मुश्किल होता है. Thank you so much. Thank you, sir. Thank you so much, sir.
We used to get married at 4 p.m. 8 p.m. with the beat. And then also at night 11 a.m. 11 p.m. we came
All the everybody says the anesthetist and surgeon, the relation is like wife and husband. They fight each other, but they stay together. So, but I come to know from them how to stay together. That is the important thing. Thank you.
I think that's a teamwork. So, because each one of us is working for the patient. So I think, but husband wife भी प्यार से रहते हैं. निकल जाती है लाइफ.
Thank you so much, sir, for the insightful session. Moving on next, the lecture is on evidence-based management and safety measures related to HIPEC. For this, we have Dr. M.D. Ray. I request Dr. Ankit to formally introduce our speaker.
It is now my honor to invite a visionary in surgical oncology, Professor Dr. Major M.D. Ray, sir.
I think we will have to postpone this lecture for a few minutes. Because Dean sir is here with us, we will first of all finish with the valedictory function. We now proceed to the valedictory and honoring of our guest speakers. I request we are pleased to have with us our Honorable Dean Sir, Professor Sanjay Gupta, celebrating with us the successful completion of the OncoSurg-BHU 2026. I request Ms. Ashruti to present a bouquet to Professor Gupta Sir as the honor of our respect for his presence. Bouquet to Sir. It is now my privilege to invite Professor Honorable Dean Sir to share a few words for our department.
Right. It's good afternoon, everyone. I'd like to welcome all of you to our beautiful institute and beautiful university. I would like to congratulate the departments. Aapka department, Onco, is really, moving ahead. One of the bad things is cancer is moving ahead. We were doing the medical reimbursements, and I said, look at the statistics. They said सबसे ज़्यादा reimbursements are for cancers. So I think, you are trying to keep in pace, and that's very good. I think you deserve a lot of accolades. And I think it's really a novel thing that you have done today. I know that there are distinguished experts of the field. And of course, they have come from premier institutes. But I, being a student of Sir, हम तो ये जानते हैं कि he is one of the international stalwarts. So it is a privilege to have Professor H.S. Shukla sir as a mentor guiding the whole departmental development. So with these words, again, I think accolades, great, everything, every day, something new is being done by your department. So really, I'm really very, very happy. And we would like to say at the institute, at the faculty level, we are there for you, with you, in every way to move forward. Thank you very much.
Thank you so much, sir, for your kind words. As we come, yes, sir. As we come close to the end of our enriching masterclass, we reflect to a day filled with learning, collaboration, and clinical excellence. From the live surgical demonstrations to the insightful CME sessions, today has truly exemplified the spirit of advancing oncological care through knowledge and skills. On the behalf of the organizing team, I extend my heartfelt gratitude to all our esteemed dignitaries, respected faculty, and all the participants for their valuable presence and contribution. Thank you for being a part of BHU OncoSurg. I now call upon Dean Sir, founder of our department, Professor H.S. Shukla Sir, Meena Sir, our head Malika Ma'am, and Tarun Sir to felicitate our guest speakers. Can we have a big round of applause for Dr. M.D. Ray sir? Even though your lecture is still yet to be done, we are enlightened by your presence. The shawl and book also. Thank you, everyone. Please put your hands together for Dr. Rakesh Garg and Dr. Amrita. Please bow.
Oh, and I missed it, sir. But certainly, कहा तो
Thank you, sir. Next up, we have Dr. Neha Kumar. Can we have a round of applause for ma'am?
बुके नहीं देगी सर हाँ तो the smiles and the fragrance.
Thank you, sir, for your presence. I request Dr. Ankit to formally introduce Professor M.D. Ray.
Time is short. We are running 2.5 hours.
It is now my honor to invite a visionary in surgical oncology, Professor Dr. Major M.D. Ray. Uh, Professor Dr. Major M.D. is Professor at Surgical Oncology, IMS, Delhi. He is examiner for MCH, DNB, and PhD programs in leading institutions across India. Pioneer of 5 cost-effective oncosurgical techniques now practiced internationally. Inventor of 5 innovative oncosurgical instruments patented by AIMS, New Delhi. Prolific author of 36 books, 14 on surgery and surgical oncology, and 22 on lecture praising science and humanities. Principal investigator in 5 translational oncology projects and 9 clinical research projects, and co-investigator in 18 multi-center oncology studies. Published over 175 research papers in reputed national and international peer-reviewed journals. Reviewer of about 10 peer-reviewed journals, co-editor of 5 journals, and editor-in-chief of European Journal of Clinical Oncology and the International Journal of Medical Research and Surgery. Member and fellow of 10 prestigious national and international professional societies. National advocate for cancer awareness, leading initiatives to prevent India from becoming the cancer capital of by 2040. Represented India in Indo-German collaborative programs on robotic oncosurgery. Graded tabla artist of All India Radio and impaneled instrumentalist representing India abroad through ICCI Government of India. Led a frontline medical team as official commanding during the Kargil War 1919, earning 5 government medals, including Operation Vijay. Sir, it is a privilege to welcome you. May I request Professor Dr. M.D. Sir to kindly come on the stage, please, sir.
So, thank you very much for long introduction. Professor Shukla sir, all the senior teachers, and my colleagues and friends. So, thank you very much, Dr. Mulika, for inviting us. This is our honor to be here. And so I'll present because we are running short of time. Just I'll go through it slightly quickly, you can say. So, why this is you have given this one? So, when I talk about only the cycle that what is the measures to be taken, state measures, that is very important thing is there. Then I go through slightly another slide for the indication of that patient to already indication for the high rate. So that is most important. You just go through this. That is good. That is safety. So that is most important. I think being all the surgeon, not only the surgeon, even the anesthetist should know what are the safety measures during sterilization happen. Most important. But usually we neglect, So that's why I think you should know that is the most important topic to say. So, see, if you see this is the literature, if you see this, that is published in America, and what are the mortality among surgeons in the United States. You just see this thing that 56% higher than the other physicians. So even if you see the Indian people, there is a statistic here, the surgeons having less, 6 years less lifespan than the contemporary other their colleagues. So just imagine kind of thing, why the surgeons having the less lifespan. So that I just talk, you see this is also one important study there, police study, that column study there. They mentioned in the study that is the surgeon's life and those who are other like physicians, they have the 6 years difference is there in the lifespan. Even in the ladies also that is 9 years, if the lady surgeon is there. So just think about that, there is a published paper and that is to some extent, but why it should be? So this is my objective, occupational hazards in cytoactive surgery, high tech, what are the chemical composition, electrosurgical smoke and associated with the health effects, hazards of occupational exposure of cytotoxic drug during high tech, safety measures during CRS high tech. So what are the overall precautions we can take in this high tech, during high tech? So the CRS high tech gradually coming up for a long time, just in India also just 1 decade or more than a decade, that there are so many centers are there for the CRS high tech. And you are also studying like officially here. Means that is very important part gradually it is coming up for the survival advantage. But if you see CRS highway, there is a high voltage that electrobody generate large amount of the surgical smoke, and there is use of cytotoxic drug. Two important aspects is there we have to take care of. Both surgical smoke and cytotoxic drug put the healthcare workers in the risks of exposure. So that is most important. That is obvious. Everybody knows that. So, these are the indications. There are so many indications that the CRS affects symptoms of peritoneal issues happening to tumor, malignant peritoneal mesothelioma, ovarian cancer, the different setting, even the gastric cancer, colorectal cancer, even the flu sarcoma also, that people are practicing highway worldwide. So there is a huge chunk of the disease. Do the primary stage, extinction of the disease, do the electrocity, how much smoke generated, just think about that. So this is the so there are a lot of time you will be taken in the 6 to 8 hours you have to spend in office. You have to be so dedicated. So this is the area now. So now this is not only this is because we are not only the exposure only the more anesthesia even the other offering exposure potential. Both the things are there. This is, even not speed, but it's 40 miles per hour. The speed is 40 miles per hour. It is 64 kilometers per hour. The more than the speed, the smoke, the 40 is the cytotoxic drug. Both the things are so much dependent, about how they are what are the quality, both the things are interested. So the second is prevention. So that water to well, so first is that bringing little amount of surgical smoke, both the things like cutting in, cutting how smoke is related. And for that, 25% daily smoke is 95% water state, and only 10% is just being like this. So between the you getting that only that smoke, particularly between that, it's 1.007 micrometer. So whatever the speed is just because of proper, just mental inspection. It cannot be at the point 0.7 mm particles. Cannot be within 95 to some extent it can be there. But when you put all stimulating is even anesthesiologists or other staffs in the OT, they are using it. So there is a mental susceptibility.